I'm so glad you're here because today we are doing something a bit different and it's going to be a lot more interactive. We're literally jumping straight into the high-stakes world of medical decision-making. We're going to break down some actual, textbook, multiple-choice questions, MCQs, straight from the world of obstetrics and gynecology. But look, we aren't just looking for the right answers here. We are going to dissect the anatomy of the decisions themselves. I want you to see exactly how a doctor weighs the risks, interprets symptoms, and synthesizes visual clues to make the right call. So, let's put you right in the medical hot seat. Could you pass a board exam? Do you actually have the clinical judgment required to navigate real-world medical scenarios? You know, it's one thing to memorize a list of facts from a textbook, right? But it's a completely different beast to look at a patient's history, their specific symptoms, and a list of really plausibly sounding options and actually choose the safe path. Throughout this explainer, I want you playing the role of the attending physician. Think critically, listen closely to the clinical clues, and let's just see how your clinical instincts hold up. Section 1, Fertility and Contraception Safety. Let's weigh the risks. Okay, let's dive into this. Our first major theme is all about that really delicate balance of reproductive health. Whether someone is trying to conceive or actively trying to prevent pregnancy, doctors have to perform this meticulous, continuous risk assessment. Every single body is different. So let's start with evaluating male fertility. When a patient gets a semen analysis, the doctor gets back a report with a bunch of different metrics. But here is the critical question. What is the single most important marker of male fertility on that report? What's the gold standard metric that tells a physician the absolute most about the chances of natural conception? Let's look at the options. Is it A, morphology, which is the actual physical shape and structure of the sperm? B, concentration, how densely packed they are? C, motility, their ability to actually swim forward efficiently, or D, sperm count, just the sheer number present. Now, they all matter, sure, but one of these carries way more weight. If you guessed A, morphology, your clinical instincts are spot on. I mean, having a high count and great swimmers is fantastic, but if the physical structure of the sperm is defective, they just can't penetrate the egg. Morphology is usually the strongest predictor of fertilization success. It totally proves that in reproductive biology, quality fundamentally overrides quantity. Okay, let's flip over to female contraception. When doctors prescribe oral contraceptive pills, OCPs, they don't just hand over a prescription slip. They are constantly evaluating for what we call absolute contraindications. Now, a relative contraindication basically means, hey, proceed with caution. But an absolute contraindication, that is a massive red flag. It means the treatment is fundamentally unsafe for this specific patient. Off the table entirely. Let's see if you can spot the red flag here. Which of these 4 conditions is the absolute deal breaker for prescribing standard oral contraceptive pills? A, chronic renal disease. B, thromboembolism, which is the formation of a blood clot inside a vessel. C, a history of amenorrhea or the absence of menstruation. Or D, diabetes mellitus. Think about how the pill works systemically, especially how synthetic estrogen affects the body. Estrogen actually has a known effect on blood coagulation, so if you locked in B, thromboembolism, you nailed it. Introducing synthetic estrogen to a patient who already has a history of dangerous blood clots could literally be life-threatening. So what if OCPs are off the table? A doctor might pivot to an alternative birth control method, like the copper T intrauterine device, or IUD. But this device has a completely different set of rules. The copper T is localized. It sits right inside the uterus and creates this inflammatory environment that's toxic to sperm, all without using systemic hormones. But again, what patient history would completely rule out using it? Let's slowly read through these options. A, an unmotivated patient. B, menorrhagia, which means abnormally heavy or prolonged bleeding. C, a previous ectopic pregnancy. Or D, a previous history of abortion. This Socratic method of questioning really highlights how different interventions have completely different risk profiles. A copper IUD is actually known to potentially increase menstrual bleeding and cramping. Therefore, if a patient already suffers from severe menorrhagia, option B, putting a copper T in there could severely exacerbate their condition. It's a huge contraindication to consider, and depending on severity, an absolute deal breaker. And this, right here, brilliantly illustrates the incredibly complex medical decision-making process happening in real time in a doctor's office. On one hand, with the pill, you are weighing systemic, whole-body risks like thromboembolism. On the other hand, with the copper T, you're looking at very localized anatomical concerns like pre-existing menorrhagia or past ectopic pregnancies. You aren't just picking a drug off a menu, you are perfectly mapping the intervention to the patient's unique biological landscape. Section 2. Surgical versus medical management. Clinical judgment in action. Let's see how this builds as we pivot from preventative care over to active treatment. This is where you really see clinical judgment shine. When dealing with uterine pathologies, there is almost never a one-size-fits-all approach. In fact, a patient's exact symptoms or lack of them will dictate the entire game plan. Imagine this. You're the doctor. A 45-year-old woman is sitting in your exam room. An ultrasound shows she has a uterine fibroid the size of a 14-week pregnancy. That is undeniably large, right? You can physically feel it. But here is the absolute most critical detail on the board. She has no specific symptoms. No pain, no abnormal bleeding, no pressure. Based on this, what is your next step?
Let's walk through this hierarchy of interventions. You could jump straight to number 4, a hysterectomy, and remove the uterus entirely. You could do number 3, a myomectomy, and surgically take out just the fibroid. You could try number 2, medical management with drugs to shrink it. Or number 1, observation. There's this great old medical saying, treat the patient, not the scan. Since this patient has absolutely no symptoms, clinical judgment usually dictates starting with the lowest possible intervention. Surgery has real risks: anesthesia, bleeding, infection. If the fibroid isn't bothering her, the right call here is just observation. You simply monitor it. Now, what's really interesting about this slide is the stark contrast it provides to our last patient. This is our final and definitely our most visually striking scenario. Take a look at this gross pathology specimen retrieved from a 55-year-old lady. Unlike our previous asymptomatic patient, this woman came in with severe abnormal uterine bleeding. Her symptoms were so significant that she ended up needing a hysterectomy. Let's evaluate the visual evidence. I want you to really focus your attention on the gross pathology of the specimen. Do you see that large, distinct, round, whitish mass sitting right there within the tissue wall? Based on just that visual evidence, what's the diagnosis? Is it A, a leiomyoma, which is the medical term for a fibroid, B, endometrial carcinoma, C, an endometrial polyp, or D, adenomyosis? That classic, perfectly round ball of fibrous tissue is the textbook visual definition of a leiomyoma. And here's the clinical reasoning. Notice how it has a really smooth, distinct border? That immediately pushes us away from something scary like a carcinoma, because those usually have irregular, invasive borders that bleed right into the surrounding tissue. So taking a step back, it's wild to think about the heavy responsibility and the mental gymnastics required here. We've just traveled through a whole gauntlet of medical decisions. Doctors have to synthesize this huge, diverse array of information. One minute, they're weighing abstract lab metrics like sperm morphology. The next, they're balancing systemic blood clot risks against a patient's vascular history. They have to hold themselves back from operating on massive but silent masses, and then turn right around and diagnose visual pathology like that fibroid we just saw. It's like a giant puzzle of clues. Which brings us to the end of our explainer, and to one final provocative question I want to leave you with. How well do you know the decisions being made about your own body? I really hope sitting in the medical hot seat today gave you a profound appreciation for the sheer depth of medical expertise and all the careful, invisible logic behind every single prescription and procedure. More importantly, I hope it inspires you to ask better questions the next time you're in the doctor's office. Thanks for diving into the clinical details with us today. Keep asking questions and keep learning.